Assalamualaikum.
Waalaikumsalam.
Dah ada semua dah ke ni? Boleh start dah ke belum? Ada MC ke apa? Tak ada ni? Ke aku start je? Hello?
Start je doktor.
Start je? Senyap je semua ni. Okay? Assalamualaikum. We start our session with Al-Fatihah. Ya, Okay. So tadi pagi yang mana yang tadi session sebelum ni apa topik dah? What was the topic kan?
Postpone, Mister.
Postpone.
Lah. Awak tak khabar Kau tak boleh aku start awal. Korang punya exam bila? Sambar ni tak cakap. Sambar.
Ya, dah.
Kau punya exam bila?
Exam pro ke exam apa?
Exam pro lah. Exam pro lah.
Mana belas?
Apa dia?
17 November.
17-11.
17 November. Oh, lambat lagi lah. So, kalau aku cakap sekarang ni, korang ingat tak? Confirm lah tak ingat tak? Tak?
InsyaAllah.
InsyaAllah. Okay, fine. So, I was told to give something about... So, orthopedic ada berapa topik yang diorang cover dalam ni? Aku nampak sambar je. Yang lain semua refuse tu tunjuk muka. Aku rasa korang semua tak ada sebenarnya. Ataupun dekat tempat makan. Tunjuk lah muka sikit. Allah. Malu sangat. Afiq. Semua yang tunjuk muka yang bekas grup aku lah. Takut kena marah ni. Oi, Aina ada lagi punya. Okay, alright, fine. Apa tadi? So berapa slot yang orthopedic ada untuk korang punya revision ni? Ke dah ditiadakan? Anyone boleh jawab? Sambar?
Yang kita orang cuba range dalam 4 ke 5.
4 ke 5. Because Murad bagi tahu cuma ada 2 ni je yang sports dengan LLD. Is that true?
Setakat ni baru macam hari ni kita plan 2. Lepas tu macam kita cuba buat terap tapi tak banyak topik sekali buat.
Okay. So akan ada lagi lah. Okay, fine. So I think I should talk to you about the cases yang akan datang dalam exam lah, right? The clinical cases, okay? I wouldn't go into depth because if you want to go into depth, maksudnya very detailed, that one more of you punya written exam. Tu kena baca sendiri lah, okay? But what I want to expose you are the cases that you can possibly get during your clinical exam, okay? So I was told to talk about approach to LLD. LLD is one of the cases that you can get from exam. But is LLD a diagnosis? Afiq, LLD diagnosis?
A sign.
Yes, LLD is a sign, so it's not a diagnosis. So you have to know what is the cause of a LLD. So what do you think is the common cause of LLD that you will see in the that you will get in exams? Contoh cause of LLD.
A vascular necrosis.
A vascular necrosis of what?
Neck of femur.
Okay, not neck of femur, Murad. It is the head of femur that a vascular necrosis due to the neck of femur fracture. Okay, that's one example. Anything else?
Osteoarthritis.
Osteoarthritis of what?
of the knee.
Would that present with significant LLD? Fik?
With chronic. Yeah, chronic.
Okay, but what would be more prominent in OA, severe OA yang dah lama? What would be more prominent? Usually. Yang kau akan nampak terus rather than the limb-length discrepancy.
Varus deformity.
You may see the deformity. The deformities are the one that is more obvious, okay? Varus ke, valgus ke, okay? But the deformity is the one that is more obvious rather than the shortening, okay? Yang AVN secondary to neck of femur fracture, yeah, but we have a few because usually if through AVN, patient will be in pain, so it's a bit difficult for you to examine, difficult for you to clark and sebagainya. It will be in persistent pain. Even you want to move the hip will be painful. Okay, but what would be a common cause of LLD that you will encounter?
Malunion of
Septic
the
non-union.
femur fracture ataupun tibia fracture.
Yes, Rifdi, Anissa. The union problems in fracture, right? Complications of fracture lah. Okay. So you get malunion, you get non-union. More common is non-union. This one will lead to shortening. Okay, I think I had a few of your groups that I've already talked about this complication of fracture. Okay, and I've already introduced this non-union punya problem lah. Okay, so let me show you. Bagilah aku share screen. Siapa yang handle ni? Can you allow me? Dah belum? Hello? Siapa yang jaga ni? Sambah. Aku nak share screen tak boleh?
Sekejap, Mr.
Okay. Yang lain-lain ni semua ada Bukan tidur.
InsyaAllah ada, Mr.
Ada? Okay. Alright. Someone describe this first. Anyone want to try? Sebelum aku sebut nama. Aku sebut nama, aku kenal group aku dulu. Siapa? Aina lah, Aina. Aina apa nama penuh kau? Tak ingat Aina. Yang tunjuk muka sejak tadi, Aina. Hello. Nampak tak gambar ni, X-ray?
Nampak Mr.
Okay, Aina, cepat.
So this is a X-ray of the anterior posterior view of the
Ni right, Sorry,
right hip. So as we can see, there is fracture over the neck of the femur.
Why do you say that?
Apa dia?
Why do you say there's a fracture there?
Because there is loss of the cortical lining from
Mana?
the inferior.
Okay.
Inferior to, and then loss of the lining.
Ni lah, more obvious is your superior, right?
Superior,
Ni,
okay.
Dengan ni kan, dia pecah kat situ. Okay, lagi?
Yes. And
What else yang
then,
suggest you this is fractured?
the
Shenton line.
Where's the
the
Shenton line?
Shenton line.
Shenton line kat mana? Cuba describe kat mana? Where's your
start
Shenton line? Start from here.
from top bukan.
Ah. Mana Shenton line? Mana cepat?
Shenton line from the middle edge of the femoral neck
Okay, alright.
sampai interior edge of the superior pubic ramus. Pubic rami.
Inferior edge.
Inferior edge.
So sini lah. Okay, so this should be
Ah.
your Shenton's line. Okay, so this Shenton line is broken. Dia naik ke atas kan? Okay,
Yes.
so it's broken. So Shenton's line is broken and also the neck of femur. Okay, how would you classify this?
Classify.
Hmm.
Yeah.
Tengok.
Okay.
Okay, what do you say is garden 3, Murad? Oh, all 4. Okay. Murad kata 3 or 4. Which one? Okay lah, I don't think garden is very important for you to know lah. Okay. But anyway, you can know. But it's not 4, it's actually 3. Okay. Because 4 is when your head re-rotates back to its normal position. This one, the fracture is still pushing the head and it is rotating out of position. Okay. So dia tak align balik, dia punya trabecular is not realigned back. In a 4, they're very much displaced that there is no contact between you punya neck dengan head. So your head will actually re-rotate back, correct back its position. But in this case, there is still a bit of contact, so it is still pushing the head and it is rotating out of way. Okay, so this is actually 3. Right. Anyway, maybe not that important for you to know. At least you know what classification lah. Then this is what happened after a few years. Okay, so what happened here? Anyone? Sclerosis. Okay. Aku sebut je nama ni. Siapa hamba Allah yang dia punya nama titik je ni? Sambah. Siapa hamba Allah yang titik ni? Cepat. Titik.
Tak tahu.
Sekejap. Yang titik ni jawab. Siapa yang titik ni?
Gambar pun tak ada.
Itulah Sal. Noktah. Siut lah. Letak noktah. Macam mana orang nak tahu siapa? Sambah, nanti kau cari bagi tahu aku siapa. Boleh Sambah? Kau buatlah macam mana kau nak buat. Anyway. Ayuni lah. Nur Ayuni. Cepat. Describe me. Hello?
Hello.
Ayuni ada tak? Ni Ayuni
Hello.
group aku dulu kan? Hello? Ayuni?
Yeah.
Describe me.
So, there is sclerosis
Okay.
at the head of
Sini.
femur.
Mana sini?
Situ.
Okay. Lagi?
So, loss of Shenton line tu, and then
Shenton line. Okay. Lost sikit. Okay. What else yang obvious?
dia punya ankle.
Dia punya? Mana dia punya ni? What is this? Is this a
loss
normal?
of joint space.
Bukan loss of joint space. Is this a normal head of femur, Ayuni?
No.
Mana pergi?
Abnormal.
How would you describe this? Head of femur dia tak ada kan? You tak nampak bulat kan? Betul tak? So this is your AVN yeah. Your head of femur dia dah collapse. It has collapsed. There is no more head. You see it's flattened. Okay. So usually memang dia flatten dekat area yang sclerosis ni, the area of highest pressure at this area. And then your whole femur is shifted upwards. That's why your Shenton's line is gone. Okay, and your head of femur is gone. So this is an example of AVN ini. And a complication of fracture tadi lah. And this one will result in LLD. So if you do, okay, anyone want to refresh us on the steps in doing the LLD examination? What should you start off with? So ya, sebab ni revision kan, so takkan aku seorang yang cakap. Betul tak sama?
Walking.
Siapa? Siapa cakap ni?
Physically.
Zul eh? Okay.
We start the examination by ask patient to walk and we observe the gait.
Okay. What gait are you looking for?
Maybe antalgic.
Antalgic gait lagi?
Wetling gait.
You see, during exams, there will not be the examiner will not ask you, okay, do a LLD examination. Mana ada, right? So because your exams for the clinical exams is based on you do it together with your clerking, right? Nowadays, still the same, kan? Tak berubah lagi kan? Okay, so it will depend on what the history is, and that would give you a suggestion of what to examine. Betul tak? Okay, so dia takkan jadi macam kau kena examine LLD. So it will be dependent on apa yang patient tu complain lah. So if the patient complain of hip pain ataupun knee pain and then abnormal gait, usually the common complaint of the patient would be bila jalan dia rasa macam tempang. Rasa macam tempang ataupun jalan rasa macam pendek kaki sebelah. Then that will give you an idea dan dia mungkin ada some sort of shortening. Okay, and from the history itself, if you're thinking about, because aku tadi the two causes of shortening is mainly AVN of the hip, AVN of the neck of head of femur, or complications of fracture. So from the history, if you think that the patient is having pain in the hip with a history of trauma to the hip, or some sort of fractures of the limb and has some complications throughout the natural management of the fracture. Maksudnya ada pus discharge ke, ada swelling ke, okay? All of this can lead to complications of fracture that will end up leading to LLD. Okay, so bila kau clerk tu kau dah fikir dah apa benda yang you want to examine, right? So katalah dia complain of, in this case katalah hip pain, right? Hip pain, then ada history of fracture some time ago. Okay, so in your mind you have to do, this patient I will have to examine the hip, and maybe I may have to examine the LLD also because he's also complaining of abnormal gait, pain during walking dan sebagainya. Okay, so itu yang terlintas dalam fikiran kau. Another example is katalah patient have been complaining of abnormal leg ataupun dia rasa macam the leg tu ada discharge, looks abnormal, okay, multiple scars kat situ, alright, and then ada history of MVA, open fracture with multiple surgeries and multiple complications, put on Elizarov and whatnot, okay, and then even walking also ada some sort of problem with the gait, okay, so you have to think about possibly I have to examine the leg, examine the leg, the trauma examination of the leg, plus I have to see if there's any LLD or not. Okay, paham? So when you do that, the first thing that once you examine the hip, in this case you examine the hip as per usual, and then you look at the gait, and then what gait are you looking for just now, Zul? Antalgic gait, okay, antalgic gait, but that doesn't truly signify a shortened limb. But what gait will signify a shortened limb?
Short limb gait, wetling gait.
So how is a short limb gait? Macam mana? How would you describe a short limb gait? Bila dia jalan, apa yang nampak? What happens?
There is a hyperextension of the non-affected limb.
Hyperextension of the non-affected limb.
Apa?
Extension of what? Extension of femur, apa? Extension of hip ke knee?
Knee will be flex.
Tadi kata hyperextend, which one ni?
Flex.
Flex. Okay, so flexion of the unaffected limb. All right. Anything else?
Hyperextension of affected limb. The knee of affected limb.
Okay, lagi? Those are, yalah, kalau dia very shorten, then that's more obvious lah. But macam shorten sikit-sikit ni, not that obvious in that sense.
The
What
shoulder
will be more?
down toward the affected knee.
The shoulder. Okay, so yes, you look at the shoulder. Okay, if you see, if you see the level of the shoulder whenever the patient walks, okay, so it will dip on the affected side. Dia akan jatuh sikit. Whenever he steps onto the affected side, it will dip a bit. It is a bit different from tender lumbar gait. Tender lumbar gait, there will be an accompaniment with swaying. The trunk will sway left to right. Okay, but in a simple short limb gait, it will not. The trunk, the body will not sway. Only the shoulder is the one that dips down. And if it is truly severe, maksudnya dia punya length is very long, then betul macam Zul cakap, there will be a compensation by the non-affected limb in which it will be held in flexion, and a bit of compensatory mechanism on the affected limb. Not so much hyperextension of the knee joint, Zul, but more of equinus of you punya ankle. Tahu tak equinus?
Yes.
Your ankle plantar flexus, dia ke bawah sebab dia nak cuba compensate the length yang that is lost. Okay. Alright. Lepas tu untuk limb discrepancy, what else would you want to do after you see the gait, and then you examine the hip as per usual, and then what you want to do? So before you want to, so for you to see that there is actually shortening, or for you to screen for if there's any shortening or not, when you lie the patient down, okay? So have a look at the level of you punya what? That can be a good screening for ada tak presence of limb discrepancy atau tak?
Level of tibial tuberosity.
Tibial tuberosity, a bit difficult. What would be more? Apa Aisyah?
Look at the heel.
Heel, okay, heel boleh, but sometimes heel pun you kena elok-elok susun kan. What is the easiest? Ni just macam screening lah. Bila dia baring, kau just buat something, kau boleh nampak lah benda ni most likely ada some shortening.
Biar Aziz yang
Aziz nanti dulu, tak sampai lagi, sabar.
Medial malleolus?
Yes, you just look at the medial malleolus. Just put the two limbs, the two lower limbs together, okay? And then you see the medial malleolus, is it hitting each other or not? Okay? In a normal person, in a normal length, the medial malleolus should hit each other. Kan, betul tak? If it doesn't have any contact, then there might be some shortening. So you have to consider dalam pemikiran you that you have to do shortening. You have to do the limb length discrepancy punya examination. Okay? So limb length discrepancy punya examination is a short punya examination. So usually you do it in the special test punya segment of your look, feel, move. So your look, feel, move tu is dependent on where you suspect the shortening is lah, based on the patient punya complaint. So katalah macam case ni, you would examine the hip. Kalau ada case yang aku cakap pasal ada tibia, leg tu ada discharge, ada history of trauma, then you will examine the leg. Okay? But don't worry, if you want to examine everything pun tak apa, because this exam you will do everything right before you present to the patient, to the examiner. So the examiner will have a look at what you're doing. So we will know what you're doing. So you what the look, feel, move of the affected area that you suspect the shortening might be, okay? The problem might be. And then you can do your special test, the limb length discrepancy punya examination. Okay, so that examination, what would you start off with? What would you do first? Okey lah, kita dengar Aimi lah. Aimi, cerita daripada awal sampai habis. Boleh tak, Aimi? Aimi Akilah.
Mister tak ingat dah.
Tak ingat. Kenapa? Apa kau buat dulu? What do you do first?
Sekejap.
Kan aku bagi ikut section-section lah. Ikut tengok notes tu. Buka notes-notes yang dah terpendam lama, simpan entah mana-mana. Akmal, mana Akmal?
Ada Mister.
Mana Akmal?
Ada.
Mana gambar pantai kau? Tak nampak kan? Ada. Aimi, kau jangan lari dulu. Start dulu, Aimi. Aimi. Nanti sekejap lagi kau sambung. Aimi kena start dulu. Apa kau nak examine dulu? Oh, Aimi. Aimi. Senyap terus. Okay, Akmal. Start what?
First, look. We ask the patient to stand first. To look for any shoulder tilting. Lepas tu compensatory mechanism such as tiptoeing.
Okay, tak apa. Ni yang look, feel, move tu is you buat as per usual. Macam mana you examine, katalah macam if you suspect the shortening is at the tibia. Ataupun the problem is originating from the tibia. So you examine macam biasalah. You punya look, feel, move. Palpate where the problem might be, tenderness dan sebagainya. Okay, fine. That one tak ada masalah. I just want to specify dalam special test, you will do the limb length discrepancy punya examination, right? Betul tak? So katalah you buat, you look, tengok dia punya medial malleus tak sama panjang, and then you look at the tibia, multiple wounds, nampak deformity. So you suspect the problem might originate from the tibia. Complaint pun from the tibia, okay? So how would you do the specific limb length discrepancy punya test? So what would you start off with?
Apparent length.
You do apparent length, right? So you measure from where to where? Let me stop this one. So you measure from where to where?
Either Zephyr's sternum to medial malleolus or umbilicus.
Okay, so you can take Zephyr's sternum to medial malleus or umbilicus to medial malleus. Okay. When would you want to take Zephyr's sternum? When would you want to use umbilicus? When? Boleh pilih either one kan? Kamal, bila kau nak pakai umbilicus, bila kau nak pakai Zephyr's sternum?
Depend on the patient umbilicus. So if the umbilicus is centrally located, not deviated, so we can start from umbilicus.
Okay, so if the patient is kurus, is slim, the umbilicus is still in the center, then tak ada masalah. But in a very large patient, then maybe the umbilicus might be going multiple ways. So then you have to go to your Zephyr's sternum. All right, so that one is apparent length. And then followed by what?
True length.
True length. Okay, so how I divide it is simply like this. First, you want to determine if there is a limb length discrepancy or not. Okay. So you first do you punya apparent length, and then you buat you punya true length. Okay. So once you dah tengok ada discrepancy, then the next step would be to determine where the discrepancy is, either the tibia ataupun in the femur. So tadi you do true length, you measure from. So true length tadi you buat measure from where to where?
Assist to medial malleolus.
Okay, anything you have to do before that?
Square the pelvis.
Okay, you have to square the pelvis, right? So you square the pelvis first, and then you measure the true length. Okay, so katalah memang ada 3 cm shortening. Then the next step would do to determine. Okay, so you want to determine is it tibia or femur, so you have to do Galeazzi test. All right. for me, I don't emphasize measuring segmental. Okay, if the patient can do Galeazzi, the best Galeazzi, a patient can you can appreciate the Galeazzi test if the patient can at least do 60 degrees flexion. If the patient cannot do up to 60 degrees, it's a bit difficult for you to appreciate. Okay, but the best is 90 degrees lah. So katalah patient boleh flex sampai 60 je pun boleh. Tapi kalau patient boleh flex 30 je, is a bit difficult. Okay. So if you can get it until 90, that is better. So you flex the knee to 90 and then you do your Galeazzi. I assume you all tahu lah macam mana buat Galeazzi, right? Okay, so that from that Galeazzi, you will know if it is at the tibia or at the femur. So if the shortening is at the tibia, then settle lah. Because the aim of LLD is just to determine where the how much the shortening is and where the shortening is. Okay, if it's at the tibia, dah settle. But if it's at the femur, what should you do more? What should you do next? So you have to do Brian's triangle. So during exams, I hope you bring 2 short pembaris plastik tu. Pernah tengok tak? Short pembaris plastik, so that it makes life easier for you to do your Brian's triangle. How do you do your Brian's triangle? Hasnain lah, lama tak dengar suara Hasnain. Oh, Hasnain.
Yes, bro.
Yes, okay. Can you tell me how you do how do you measure Brian's triangle?
From assist to greater trochanter. And
yeah.
And then
so you measure what? Which one do you measure? Assist to greater trop? Is it?
Yes. I have to check back.
Oh, tak ingat.
But imaginary line to form a triangle. So from assist kena buat one line perpendicular to the back. Then greater trochanter tu pun kena buat another imaginary line. So dia kena ambil junction of macam ada junction where the 2 line meet.
Okay.
So kita ambil agreement between the junction to the greater trochanter.
Okay, so this is your assist dekat atas, alright? And then you bring an imaginary line down. Okay, so this is the first pembaris yang kau bubuh, kan? And then this one is your greater trop, okay? An imaginary line from your greater trop yang perpendicular, yang parallel to the floor, and then dia akan bersilang, betul tak? So this one is the another second pembaris. So you just bubuh kat situ. So basically you silang 2 pembaris and then you immediately dapat the length that you want. So the length is the one yang below ni, from greater trop to your imaginary line that you bring down from the assist. Okay, not your hypotenuse. Hasnain?
Yes, understood.
The one bawah tu yang kau nak measure. Okay, so if you have 2 pembaris pendek, it will be much quicker for you to examine. Bubuh pembaris satu macam tu, yang along kau punya assist, bubuh 1 pembaris along kau punya greater trop, so tempat bersilang tu kau terus dapat dia punya measurement. Okay? Alright. So once you've done that, then you have to compare with the other side. If the affected side ni yang ada shortening, so then the shortening is at the proximal femur. Okay, so then you dapatlah you punya shortening where it is. Okay, so habis lah. Nanti jap. Let me show you some. Ni aku dah discuss lah dengan grup-grup yang posting dengan aku kan. Okay, so this is an example of patients that you may get. Okay. Okay, this is a so what do you think happened here? Anyone want to comment on this picture? Anyone want to try? Aku tak dapat nak tengok nama korang ni. Banyak sangat. Nur Zakwan.
Yeah, Mr.
Kau dah ada posting aku ke tak final year? Tak ada kan? Hello?
Belum.
Tak ada. Okay. What do you see here? Tell me, what do you see?
I saw there is open wound fracture of the tibia.
Okay, I give a bit of history lah. This patient had a history of injury 2 years ago. Okay, 2 years ago, and then presented to us with a discharge and something coming out, something dekat dia punya leg ni. He's a 60-year-old diabetic patient. Okay, what do you see?
From the picture, I saw bone coming out.
Bone coming out. Okay. Lagi?
And then I saw there a lot of scars.
Multiple scars, alright.
Surrounding it.
Lagi? What about this bone? What do you think? This is a close-up of the bone. What do you think?
The bone is there was no the bone color looks yellowish. There was no tinge of blood.
Okay. So what do you think?
So I
Is
think
this
it
bone alive or not?
I think it's non-viable.
Non-viable. Non-viable bone. Okay. Apa at least gastulo 3. Are you concerned about the gastulo classification at this moment of time? Ni dah 2 years after the fracture, right? Okay. So yeah, it might have a history of open fracture before, but that's not the classification that you need now. Okay, because now macam si Zakwan cakap, you can see the bone that is coming out and the bone is unhealthy or infected, kan, Zakwan?
Yes.
Alright. So what's the color of healthy bone?
It will be whitish and there's red in color, like paprika.
Okay. Tak adalah sampai paprika. Yeah, the color of memanglah if you want to debride the bone, then you will get paprika sign. I'm just asking, what is the color of a healthy bone? Okay, for you to get paprika tu kau kena pecahkan that bone. But a normal bone, the color is lebih kurang betul juga macam you cakap, Zakwan. It is not true white. It should be a bit pinkish. You can see small streaks of red at the bone. Then that is a healthy bone. This one dia dah kuning. Dia dah yellow. Definitely is not a healthy bone anymore. Alright. So this is already a dead bone. Okay. So what do you think is the problem? 2 years. Bone terkeluar gini.
I think this is maybe due to infection.
Okay.
Of the bone itself.
Okay. So this patient complain of pain whenever he walks. What will be the problem? What do you think is the problem?
It's a non-union secondary to the infection of the bone.
Okay, so most likely because this bila ada bone kat sini, most likely the fracture has not united. Okay, good, Zakwan. So anyway, whenever you have a case that you suspect there might be LLD, one of the things are complications of fracture. Okay, so if you know the normal management of any fractures, the final aim is always for us to try to get the patient to get union of the bone, right? Okay, so if the patient has any problems along the way that impairs its ability to get the bone to unite, then the patient will start to have complaints. So the common complaint of union problems, especially non-union, would be pain, especially pain on walking, or pain on whenever they use the affected limb. Resting, usually they tak ada pain. It's not a persistent pain. It's only pain whenever the patient walks in lower limb or whenever the patient lifts heavy objects in upper limbs. Okay. So So if you get a case when a patient comes to you and then bila kau tanya patient tu, pakcik datang hospital ni sebab apa? Pakcik sakit bila every time pakcik jalan pakcik sakit. Alright? Then kau akan tanya lah the usual pain tu kat mana lah, apa benda lah. Dan dia kata pain tu dekat leg. And then you will ask what aggravates the pain, kan? You punya apa? Socrates Samba. So you will what aggravates the pain, kan? Dan dia kata pain is upon walking. So one of the things that you have to rule out is ada tak history of trauma. And then when you ask the history of trauma, dia ada trauma 2 years ago, open fracture some more, okay? And then you can ask how about the fracture? Was it united in the end? Okay tak lepas masuk besi ke apa ke? Okay tak ada masalah tak? So kalau patient tu kata ada masalah, memang tulang tu tak nak bercantum, okay? Terpaksa buang besi dah, so dia akan mula cerita panjang lebar. So your task when you want to clerk, because we will be there. And if the examiners are kind enough, if you see kau dah mula tanya panjang banyak sangat, we will try to shorten whatever yang you try to asking. Because you have 15 minutes kan, Samba? 15 minit kan? Ke 20 minit?
Around 20 minutes for clerking and physical examination.
20 minutes, right? So you only have 20 minutes to clerk and do a physical examination. So if you have my patients, advanced trauma patients, complications of fracture, if you ask very detail of each surgery that is done, you will take too much time. So you have to try to summarize. So I advise you how to summarize. First, determine what the chief complaint is. The common chief complaint for a non-union is pain upon walking or upon usage of the punya affected limb. Okay, that's the chief complaint. And then you boleh kembangkan sikit chief complaint tu, pain tu, what aggravates it most. Sejak bila dah ada, usually dah ada semenjak daripada trauma, tak hilang-hilang dia punya pain. Okay, and then you just need to kembangkan sikit the history of trauma tu. Don't need to go into depth, just at least get a history. Is it an open fracture or is it a closed? If you know where the injury is, the patient can tell you where the injury is, and you can ask them ada tak wound dekat tempat tu, ada tak luka-luka waktu accident tu. You can consider that it is an open fracture, okay? And then you can just ask them. So lepas patah tu ada tak doktor ada masukkan besi ke apa benda ke? So you know the usual flow of a management of a fracture is that if it is open fracture, you debride, you give antibiotics, debride, stabilize the fracture with X-fix or whatnot, and then you close the wound. And then you convert an open fracture into a closed fracture, and then you do the definitive management. Definitive management often in open fracture includes some sort of internal fix. All right. So if that everything is okay, during follow-ups, the doctor will see, and then they will look for union. So once the bone has union, the patient will be discharged. Okay. But if anything that disrupts this normal flow, usually it will result in non-union. Common complaint is ada pain during the follow-up, ada discharge, signs of infection. If there is any signs of infection, then you have to ask the patient betul-betul. So you ask bila kata ada you get a history of open fracture. Then when you have an open fracture, the risk of infection becomes higher, betul tak? Okay, so you have to ask ada tak features of infection. Maksudnya sepanjang masa lepas dah masuk besi tu ada tak keluar nanah, bengkak kaki, demam ke tak? Ada tak doktor terpaksa keluarkan besi sebut, tukar kepada besi luar balik. So if that happens, you know that there was an infection that occurred and they had to remove the implant dan sebagainya. Okay, so when you want to present, when you ask tak apa tanya banyak ni, but you don't have to go into detail. But when you present, just give a summary. So you kata this patient had a history of MBA about 2 years ago with a possible history of open fracture because there was a presence of wound over the affected limb. And then multiple surgeries was done. However, it was complicated with most likely infection because of past discharge, fever, swelling. Okay, multiple surgeries have done, and the latest surgery that was done, the patient has to be end up with a form of ring external fix ataupun Elizarov. Enough. Tak payah nak go very detail into what happened. Okay, so you sell to us that you're thinking that this patient has a problem of non-union, and the most likely cause of the non-union is actually infection. Okay, which is a very common cause of non-union. especially if you are able to determine that he had a history of open fracture. All right. Okay, fine. So that's the history that you want to look out for. So what physical examination to do? One is LLD. Second is if there is non-union, what examination would you want to do to prove to us that it is non-union? Regardless lah, is it infected non-union ke ataupun aseptic non-union ke? What special test would you want to do selain daripada LLD tadi? Very specific for non-union. Syuhada Hadi. Still tak tahu siapa yang noktah ni. Syuhada.
Try to move the distal and the proximal part of the affected side.
So kau nak move dua-dua? Taklah move dua-dua, move satu lah. You want to move macam mana? How would you want to move it? So you hold the proximal piece and then what do you do? Pegang the distal one and then what do you do?
Try gerakkan.
Gerakkan macam mana gerakkan? Putar ke?
Atas bawah, kiri kanan.
So you just need to memang layman tu lah. So you move it medial, lateral and also anterior and posterior. Betul tak? So if you can move in all 4 directions and you show to me that you can move in all 4 directions, then it means that it is non-union. Don't worry if you just move the non-union patient. Usually it's not painful. Okay, a non-union patient, if you just you pegang and you move it, is not painful. It becomes painful when the patient uses the limb. Okay, so don't worry about that. So you just do that, then you prove to us that there is non-union. Then we are happy. Okay, so this is the X-ray. So if you are thinking that this patient is having septic non-union, right, infection macam Zakwan cakap tu, yes. So do you think osteomyelitis is there? Ada tak presence of osteomyelitis? Siapa nak kena ni? Siapa? Nick Akmal. Oh, Nick Akmal. Ada tak Nick Akmal?
Ada, doktor.
Mana kau? Tak ada. Ada? Jawab.
Ada.
In a septic non-union, okay, the history of open fracture comes to you with sinus discharge, pain on walking, you suspect a septic non-union, right, or infected non-union. Do you think osteomyelitis is there?
Yes, doktor.
Kenapa Awatif punya ni pula yang ni?
Mak saya rosak.
Oh, okay. Baru nak tanya Awatif. Okay, fine. So if there is osteomyelitis, how would you classify it? Awatif boleh tolong.
Ada for chronic osteomyelitis, we can classify it according to Cerny-Medder classification.
Ni siapa jawab ni?
Awatif.
Awatif, okay. Cerny-Medder. What do you mean by Cerny-Medder?
For Cerny-Medder.
Okay, how would you classify? This is the X-ray of the patient.
Doktor.
Oi, merujuk buku. Korang kan dah final year. Mana payah rujuk buku dah?
According to this X-ray ke, doktor?
Ni X-ray patient tu lah. Ni dia punya clinical pictures. Ni X-ray dia. Do you see this? Nampak tak piece ni? This piece is the one which is outside. Ni piece ni outside. Okay. Ni yang terjolur keluar ni. So what do you think is the classification if there is osteomyelitis? So setakat kau tahu dia punya nama je lah, nama orang, Cerny-Medder.
Kalau dia ada dua dua karakteristik. First anatomical characteristic of bone involvement.
Okay.
And then second is for the physiological status of the patient.
Okay. So physiological status, 60-year-old diabetic. And you can see this leg. So how would you classify him?
Kalau diabetes mellitus B because of systemic compromise, underlying DM, and then for anatomical characteristic depends on the bone involvement. Kalau tengok gambar ni diffuse ke doktor?
Why diffuse?
Sebab it involves circumferential.
Yeah,
bone.
because the whole bone, this whole bone is involved, right? So how do you want to differentiate diffuse and localized?
Kalau localized, it involves full thickness of the bone, but does not affect stability.
Okay. But it involves usually one cortex, all right?
One cortex,
It doesn't involve multiple cortex. So this is an example. Okay, good. Awatif, kau baca
Baca nota doktor.
Baca nota aku. Anyway, so you ada dua. Whenever you want to classify any osteomyelitis, you have to remember you follow the Siani-Meder. This is one of the classifications that you have to know, which is outside of your fractures. Selain fractures, classification on fracture. One other classification that you have to know is your osteomyelitis. Okay, so it is by Siani-Meder, and it is divided into the physiological classification, the host classification, and also the anatomical classification of the affected bone. All right. So the host classification, you ada A, B dengan C. A healthy, B impairments. They can be impairment the local condition and the systemic condition, or both. So in our patient, do you think it is systemic conditions only? Awatif? Systemic sahaja ke? Diabetic. Local condition tak ada? Local impairment tak ada?
Local impairment macam ada sebab ada scarring.
Yeah, you see a lot of scars. Local impairment meaning there is impairment to the patient's ability to heal. You cannot palpate dia punya pulse, but at least you can see that there is multiple scars. When there are multiple scars like this, the ability of the skin or the soft tissue overlying the bone becomes for it to heal becomes impaired, right? So there is a local compromise, and there is also a systemic compromise because of dia punya diabetes. So this patient ada both. So BLS, so this patient is considered dalam BLS, all right? If the patient is C, is when the patient is a moribund patient, meaning if you do treatment, the patient may die because of the treatment of osteomyelitis. Okay, so this is very bad patients, very sick patients. Often we don't have any options to do anything for them. Okay, so the next one is your anatomical type. You ada medullary, superficial, localized, and diffuse. Medullary is just simply infection within the bone, within the medulla. And superficial is infection that involves 1/3 of the outer cortex. What example can you give for this? A good example that you can have superficial infection? Anyone? Siapa yang tumpang mikrofon Awatif tadi? Siapa nama? Nick apa? Nick juga. Hello.
Tak sure doktor.
Hai, terus tak sure apa yang kau rasa ni? Cubalah tengok sikit gambar ni sendiri dah suggestive.
Jadi doktor.
Kau tolong jawabkan apa orang lain jawab.
Tak ada notes.
Ulcer lah, DFU ulcer lah. Tengok ni, dia nampak macam ulcer kan? Okay, so your foot ada bone juga. Dia ada you punya metatarsal dan sebagainya. So if you have an ulcer that goes over the bone, when it involves part of the bone, you can get superficial type of osteomyelitis, all right? And then you can get localized when one cortex is involved. So macam Awati cakap, yeah, one cortex is involved, but the stability is maintained, all right? So maksudnya, if you want to remove the affected area, an example of localized is like this. Sorry. Okay, this. This is the classical X-ray that describes chronic osteomyelitis. Huh? What do you see in this classical X-ray? Mana panggil brothers pula siapa? Zaki. Zaki Iqbal. Come.
Yep, Mr.
Describe this. This is the classical X-ray that describes that shows that represents chronic osteomyelitis. What do you see? This is a femur X-ray. What do you see?
New bone growth.
New bone growth, okay. Lagi?
Lepas tu tengah.
Tengah ni apa? Apa? Rujuk nota cepat. Anissa tak aci. Anissa sebab kita orang dah discuss. Betul tak Anissa?
Betul,
Anissa?
betul. Ya, betul.
Aku baru discuss. Sedap lah kau jawab. Sebab tu aku tak tanya kau. Anyway, Zaki, so what do you see? What do you call yang you punya bone growth? Yes, I agree with you. There is a lot of bone growth here that you see. What do you call that bone growth? And why do you get this extra bone growth?
Sequestrum.
Ya ke sequestrum? Itulah, kau jangan buta-buta ikut si Anissa tu. Kau tak tahu apa yang dia jawab. Apa bone growth ni? Murad pun dia dah discuss. Boleh lah. Okay. This is a classical X-ray that represents chronic osteomyelitis. Okay. So you can see you can see majority of what is often described when you talk about chronic osteomyelitis. You can see sequestrum, you can see involucrum, you can see halo sign. Okay. So the sequestrum is simply dalam ni, and what it means, sequestrum is dead bone. Okay. So you have a dead bone within here. This bone is already dead. And then you will have a reaction of the surrounding living bone. Okay, so the reaction of the surrounding living bone is what we call the involucrum. Okay, you had a sequestrum and then involucrum. Now the halo sign is this empty space around the sequestrum, usually filled up with pus dan sebagainya, debris dan sebagainya lah. So this is the halo sign. It is like a halo yang dekat atas kepala angel tu, kononnya lah. So this is a halo sign, alright? So why it forms? Because the living tissue will never be able to incorporate a dead tissue. So dia akan try to encapsulate dia macam ni. Okay. So you dapat this halo sign with sequestrum in the middle and involucrum outside. Over time, if it is left be, and then it will form a cloaca. Cloaca is basically when part of the involucrum breaks off, dia jadi macam pecah. And then they will form a sinus which connects between this involucrum yang dah pecah ni keluar. So along that route, a sinus will form. Why the sinus is being formed? Because the body is trying to eject this sequestrum. How the body tries to eject, dia pecahkan involucrum and try to keluarkan dia through sinus. So usually kalau dia punya sequestrum kecil, dia akan start to keluar dalam serpihan-serpihan halus. Okay? But in this patient belum lagi form. Okay, so this is a good example of a localized type of osteomyelitis, right? So only one cortex is involved, and even if we remove the sequestrum, the stability of the whole bone is preserved. Okay, but in our case yang kita discuss tadi, this case, this whole bone is already outside. Okay, this whole bone is already outside. So, and then the fracture is not united. Okay. So in any septic non-union, because the fracture is not united, most likely the whole circumference of you punya bone is involved. So dia dah jadi diffuse. So if we debride, we remove whatever infected material, infected part of the bone, the whole bone will become unstable. Okay. So the main difference between localized and diffuse, one, the number of involved cortex. Okay. Second is whenever we remove whatever infected material in diffuse, the bone will become unstable. in localized, the bone will remain stable. Okay? Right? So I hope you can describe the CNA Medder punya classification. If we give you a situation like that, you can describe it clearly. Okay. What else? Okay. So how do you manage septic non-union? Give me the principles of management. Yang dah ada kelas dengan aku, sila tahan daripada menjawab. Memang aku tanya sikit. Mana Nasiha? Nasiha. Tak kenal lah Nasiha ni.
Ya, Mr.
Ada? Okay. Give me the principles of managing a septic non-union ataupun infected non-union. What are you going to do?
Okay. So, kalau untuk first kita kena identify dulu if this fracture tu open or close fracture.
Okay.
Lepas tu kena bagi antibiotic prophylaxis.
Kenapa prophylaxis? Sekarang ni kau dah establish patient yang macam gambar kita tunjuk tadi, memang ada infected non-union, alright? So kau nak bagi antibiotic prophylaxis lagi ke?
Tak, antibiotik. Okay, so kita
therapeutic.
ada therapeutic.
Okay.
Kita kena bagi antibiotik. So dia boleh jadi dalam bentuk antibiotic impregnated beads.
Okay.
So lepas tu kita boleh bagi systemic antibiotik lah untuk sebab dia boleh ada presence of biofilm. Jadi
Okay.
kena bagi dia systemic antibiotik.
Okay, dah tu je.
Lepas tu after that kita boleh plan untuk debridement.
So kau bagi antibiotik dulu before debridement?
Tak, kena tengok patient tu stable ke tak. Kalau patient tu stable, tak perlulah bagi antibiotik before debridement.
What do you mean stable? So kenapa kau cakap tadi antibiotik dulu? Kan? So, okay. Nasya, aku ajar kau macam mana cara nak jawab. If you want to answer the principles of management, okay, you always, the examiners often they want to see you punya susunan juga, okay. So betul lah you kata tadi, first you identify ada ke tak osteomyelitis, ada ke tak septic non-union in the first place, alright, fine. Through history and physical examination. So now you've come to a diagnosis of septic non-union, most likely septic non-union. So how do you manage? We don't give antibiotics first, okay? Because macam kau cakap lah, kalau kau bagi antibiotik dia ada biofilm lah, benda tu tak tembus. So we have to do debridement first, unless in certain cases in which, contoh, what examples that you have to give antibiotics first?
Kalau dah start ada biofilm.
So ada biofilm je kau bagi antibiotik first. What do you think is better if you have biofilm? You remove the biofilm ataupun you give antibiotic? Which one is better?
Kena remove biofilm dulu.
Remove lah better, right? Betul tak? So the only situation in which, when we're talking about septic non-union, the only situation, because you dah tahu ada infection, the antibiotics is therapeutic. The only situation that you have to give antibiotics before debridement if the patient presents to you in sepsis. Maksudnya the infection is very bad that it has involved the whole body, dia dah jadi septicemia. Then kau bagi antibiotics dulu. But your aim is trying to reduce the septicemia, the blood-borne bacteria, rather than the localized bacteria. Okay. Only in that condition you have to give antibiotics first. But it is quite rare in septic non-union for patient to come to you with septicemia. Okay. Usually it's just localized sinus discharge with some localized infection punya symptoms. So you start off with debridement first. Okay. So what's the aim of debridement, Nasya? Apa kau nak buang?
Debridement nak buang
Apa yang you want to remove when you debride a septic non-union patient?
Buang apa dead tissue which
That lagi?
and also
That infected
yes that
that infected
and
and
also sebab kita nak buang source of infection tu lah.
okay, so you want to move that infected or foreign bodies ataupun non-living, kalau macam ada implant ke apa ke, kau kena buang juga. Okay. So how much you want to remove? I think I assume you remember dalam open fracture management kan? Do you remember? You have to remove soft tissue and you have to remove bone. Soft tissue is depending on the forces. Up to you, so you have to remove sampai you jumpa the forces. Okay, bone you have to remove until you dapat your paprika sign, kan? Betul tak, Nasha?
Betul-betul.
Okay, lepas tu?
Lepas tu barulah kita try buat skeletal stabilization.
Okay. By putting what? X-fix. Boleh bubuh internal fix tak?
Sebab infection kan.
So?
Kena buat X-fix dulu.
Okay. Because we cannot put internal fix because we don't know if we have removed all of the bacteria kan, the infected material. We will never know clearly just immediately after debridement, kita tak tahu. So it is not safe to put an internal fix. It is safer to put X-fix, okay? So you stabilize with X-fix and then?
Lepas tu barulah buat wound management dengan cara kita buat closure of the wound lah. So benda ni kena depend kepada extent of infection tu.
Okay, you confuse sikit dengan open fracture. Wound management more of open fracture. Jarang septic non-union ni dia ada big wound. Usually dia ada sinus je. Okay? So kalau ada sinus je tak payah nak wound management sangat lah. Okay? But more importantly, after you dah stabilize, you have to start antibiotics lah, right? Kan? Start antibiotics. What were you talking about in antibiotic impregnated semen tadi? What do you mean by that?
Dia ada, maksudnya Prof nak tanya, doktor nak tanya apa?
What do you mean by antibiotic? You cakap tadi antibiotic impregnated semen
Betul.
What is that?
Dia adalah beads yang menghasilkan the dead space. In the beads tu dia ada antibiotic. So ada advantage lah, dia high local concentration.
Okay. Okay, good. So basically you have the beads which is formed by cement, and within that cement there are the antibiotics. So if you put it there, the antibiotics will leach out over a prolonged period of time. So it increases the local concentration of antibiotics. So di samping tu kau bagi sistem antibiotics juga kan? Okay, lepas tu what do you do next? So you debride, you stabilize, you give antibiotics, lepas tu?
Lepas tu kena monitor kot, tengok dia punya sign of inflammation. Lepas tu ada discharge ke or ada fever ke.
Monitor, how long?
Monitor 2 weeks, not sure Prof. 6 weeks.
What do you think? Ortho suka 6 weeks kan?
6
Ortho is 6 weeks, okay? So you have to give antibiotics for at least 6 weeks and monitor. So you monitor what?
Saya monitor, tengoklah white blood cell dia, inflammatory marker, ESR dengan CRP.
Itu je?
Tengok sign inflammation, tengok patient.
You start off with clinical dulu lah, Nasha. So I would monitor the patient clinically and also through lab investigations. So clinically, I would look for signs and symptoms of infection, swelling, discharge dan sebagainya. And then lab investigation, I would look for white cell count. Kita jarang guna because white cell count is more for acute punya infection. We often use you punya CRP and ESR. Okay? Understand? So after 6 weeks, at least giving 6 weeks, kalau everything is normal, clinically okay, lab investigation okay, baru we can go to the next stage. Okay, thank you Nasya. Good. Siapa nak try satu lagi? The next stage is Hadirah no. Hadirah. Mana Hadirah? Halo. Ada Hadirah? Oi, tak jawab senyap. Halo, Hadirah ada? Hadirah? Tak ada. Okey, Akmal lah jawab, Akmal. What's the next step?
After we divide and also the infection settle.
Tak dengar, cakap kuat sikit.
After the infection have settled down, we plan for depend on ni apa bone gap.
Okay. So you nak manage the union lah kan? You want to manage the union. Okay, you want to manage the union, and management of the union is dependent on the bone gap that we left during the debridement. Okay. So majority kita buat bone graft dengan bone transport, right? So if the gap is 3 centimeters and below, we can change your external fix into internal fix and sumbat bone graft kat situ. Okay. If the gap is more than 3 centimeters, then we will opt for bone transport. All right. So let me show you one example of our case that we have managed. Sorry. Tak buka lagi. Sorry. Aku cari jap. Okay. Okay, so this is an example of our patient. You see this, Dia nampak? Okay, so this is patient kita orang nama Zaume. So this is the initial presentation. He had a history of open fracture with persistent sinus discharge from this area for many years, 2 years. Okay, so when we did X-ray, this whole area, this is clear sequestrum, this is clear sequestrum, and then this whole area looks infected. Okay, so we've gone in and did a debridement. So when you do a debridement, we have to remove this whole thing. Okay, so we ended up with this. So if you see this X-ray, we've put it on Elizarov. Okay, and then this is the gap that is left. Besar kan gap ni kan? Nampak lubang ni, right? So this small bulat-bulat thing is the gentamicin beads that we've inserted there. Okay, so now we are trying to do a bone transport. So we've cut this area, and then we purposely cut proximal part on a healthy bone. So we've cut here with the aim of trying to transport this distally. Okay, so this is what happened over time. So this is the area that we've cut, and the patient is transporting this piece slowly distally. Okay, so this is more. Okay, so this is a bit more time. So you see that this area, kalau nampak on lateral view, nampak jelas sikit. This area is the new bone that we've pulled. The new bone that we've pulled apart, the regenerate that we call, and this is the residual gap that is left. Okay. However, we were unable to bring it closer together because patient dia dah tak larat dah pakai Elizarov ni lama-lama. So we opted to change to this. What is this? Do you know this? Ni ada bone kan? Kita bubuh another bone here to fill up this gap. Now this is actually your fibula. We took a fibula from the other side. This is what we call the vascularized fibula graft. It's a bit difficult, more difficult to do because you need a microsurgeon to come and help. This one we asked Mr. Azim untuk tolong. So we bring a piece of the contralateral fibula with its own blood supply. We bring it to the affected site, and then kita sambungkan blood supply fibula tu kepada local blood supply. Right? Unfortunately for him, because he also has multiple problems, other comorbids, that vascularized fibula failed. Okay, if you see here, this vascularized fibula, dia dah jadi sequestrum by itself. Okay, dia dah jadi infected, dia dah mati. Dia dah nampak hancur-hancur dah ni, dia dah jadi sequestrum. Okay, so we had to remove it again and restarted back our bone transport. Okay, so the gap is lesser dalam 5 centimeters. So we cut a new one on the proximal here. And then we transported him again. Okay, so this is the one dia dah makin besar. Okay, and then this is the latest one. Okay, you see this is the transport that we have achieved, the regenerate that we have achieved, and now the bone dia dah rapat. Okay, even though dah rapat ni, dia still a bit shorting dalam 3 centimeters. So once dia dah rapat macam ni, our aim is to change this one into an internal fix and then bubuh bone graft dekat that area, because we have shortened the gap to a smaller gap, so then you can go into the management using bone graft macam aku cakap tadi. Okay, so if somebody asks you, so this patient you dah give a diagnosis of septic non-union. Okay, often they will ask, so how would you manage? So maybe you don't have to go into depth about the bone transport dan sebagainya. That is the end part of your management. You should start off with, there are 2 problems in this patient. One is infection and second is union. I would address the infection problem first. And then kau cakap lah, I would debride the patient, put temporary stabilization, give antibiotics, and then monitor. Once I am confident that the infection has resolved, then only I will go into the union management. Now the union management will be dependent upon how much of a gap that had to be removed during the initial debridement. If the gap is less than 3 centimeters, I can just go in and put a bone graft with internal implant. However, if the gap is too large, then I may have to opt for other methods of management, likely bone transport. Okay, cukup. That is good enough. We are happy enough. You will get distinction if you will be able to answer like that. Okay. Maybe kau rasa bunyi ada bunyi, dengar bunyi bising tak, Samba? Tak ada? Okay, ada orang potong rumput kat my house. Anyway, so any questions with regards to this? This is a common case that you will definitely get during exam. Okay, one other case that you can get is this. With regards to fracture complication, let me show you this. Anyone want to attempt this? Siapa nak try describe ni? Okay. Siapa Aimi baliklah, Aimi. Tadi kau tak jawab kan? Oh, Aimi. Hello.
You, sir.
Describe ni. Cepat. This is a tibia. Tahu tibia kan? Tibia. Okay, what do you see?
Fractured.
Okay. Tapi ni dah lama, dia dah 2 years.
That's sclerosis.
What would you comment on that fracture?
Non-union fracture.
So it's not united lah. Okay, good. Why do you say it's not united?
Sebab proximal dengan distal tu tak bersambung.
Tak bersambung. Ada line ni lah. Okay. Anything else you want to describe selain daripada ada line?
Ada sclerosis.
Sclerosis.
Tak.
Okay. Anything else? Ni yang besar ni normal lah, besar ni. Nampak yang besar ni? What is this? Apa yang besar ni? Ni tak ada clinically tak ada features of infection. So is aseptic lah. What do you think? Bila ada fracture, what does the body try to do to heal the fracture? Dia akan form
careless
lah kan? So this is callus. So callus, a lot of callus with non-union. What do we call that? What do we call that?
That's
Huh?
hypertrophic.
Hypertrophic?
Non-union.
Hypertrophic non-union. Nah, kan? Because basically you ada callus banyak, tapi the bone is not united. Now, what is the problem yang menyebabkan dia tak unite? Aimi. Continue cepat. Boleh. Kita dah discuss ni dulu. Kita dah pernah discuss dah. The body can form callus, right? Dia boleh form callus, tak ada masalah. But the callus tak dapat nak bridge, tak dapat nak unitekan that bone. Why do you think that happens?
Maybe sebab mechanical dia tak
Dia tak? Dah hampir betul tu. Come on. Mechanically dia tak?
Stabil.
Dia tak stabil. Yes, betul lah. It's unstable mechanically, right? So the stability of the fracture is not maintained well. All right. So whenever the bone tries to form callus across the fracture site, it moves and then it breaks that callus, so dia tak dapat nak join. All right. So it's unstable. So the management is apa, Aimi?
Stable the fracture.
Yes, make the fracture stable. Okay. In this patient, he was managed. He was managed with POP and then he defaulted management. So he came back after multiple months. Tengok POP semua dah lunyai, and then fracture dia memang tak unite. Dah dapat hypertrophic non-union. Okay. So we had to change to an internal fix. We put in a nail, and then the fracture united well. Tak ada masalah. Okay. So another form. So this is one example of an aseptic non-union. So this is another example of an aseptic non-union. What is this? Siapa? Ahmad Najhan. Ahmad Najhan, are you around?
Yes, Prof.
Ada, okay. What do you see here? This again is aseptic. There is no signs of infection. Is it united or not?
Not unite.
Not unite. Okay, good.
So this is.
So why do you think it isn't united?
This bone gap and also no callus.
Okay, bone gap, no callus. So what type of non-union is this?
Non-union.
Yeah, it's non-union. Kalau tak unite, non-union lah. So what type of non-union is this? Apa?
Atrophic non-union.
Atrophic. Why do you say it's atrophic?
Because no callus formation.
Is it just no callus formation? What does atrophy mean? Atrophy mean mengecil kan? You ada is opposite to hypertrophy, right? So atrophy. So what do you see in this X-ray? Nampak tak bone atas ni macam ni, bone bawah ni macam ni, sampai dekat fracture site dia mengecil kan? Betul tak? Dia macam penciling. Okay, why does this happen? So this is the atrophy lah, the atrophic non-union yang mengecil ni. But why does it happen?
Maybe because of poor vascularity in the area.
Good, because of poor vascularity in the area, because of the fracture itself, ataupun an attempt to fix the fracture and then we remove the periosteum, so it becomes reduced blood supply at this area. Hence, they dapat atrophy. So how do you manage? What can we do to get it to unite again? Apa? Agak-agak cuba fikir sikit, logik sikit. What can you do? What can we do?
So
macam tadi hypertrophic non-union unstable, so you make it more stable, right? So in this case,
improve the vascularity.
So how do you do that?
So first risk factor management.
No lah. What would you do to handle this? Yeah, risk factor tu satu hal. But what would you do to make sure they unite?
remove the atrophic bone.
Okay, good. You have to remove first. You have to remove the atrophic bone first, and then
Put graft.
bone graft. Okay. So usually the atrophic bone is not that much, maybe dalam 2 centimeters or less. So you just have, because when you have atrophic bone, its capability to heal is not there anymore. Betul tak? So you have to remove it. Dia macam necrotic bone lah. Kau kena buang. Dia dah ischemic bone. So you have to remove it. And then you have to fill up that gap with bone graft. And then you put an internal implant. Okay? So usually because the gap is usually not that much when you're dealing with atrophic non-union, is usually less than 2 centimeter. The gap yang besar-besar ni in infected non-union. Alright, so you just remove the affected part, put bone graft, put an internal implant, settle. Okay, Najan? Alright. So now one last question. If somebody asks you, how do you determine that fracture dah unite atau tak? How do you assess for union? Siapa aku nak panggil? Umil Khair.
Yes, Doctor.
Did you listen to my question?
Yeah.
Okay.
Maybe we can assess the stability when patient weight bearing or any.
What do you mean
signs
assess stability? So katalah patient macam ni, this X-ray patient ni kita manage dengan nail, internal fixation with a nail. How do you want to know the fracture dah unite atau belum?
Based on X-ray.
Okay.
See the formations of the.
Okay.
See the formations of the callus.
All right. What do you mean? When you look at this, is it united or not? This one.
The not united yet because there is.
Ada fracture line.
Still ada lagi fracture line.
So selagi ada fracture line, selagi tu belum unite lah. So for you, union is this one. Kan? Tak ada fracture line kan? This one kan?
Yeah.
Okay. How about I tell you this one is after 3 months, this one is after 2 years. So the fracture will only unite after 2 years, is it?
No, not really, Doctor.
It's too late, right? 2 years.
Too late. So dia kalau dia if 3 cortex in unite tu, so kita boleh say yang
baru jumpa nota baru jumpa nota. Aku tahu.
Someone help me.
Someone help you. Okay, so what do you mean by that?
So macam
ada pembantu tu punya.
So
what do you mean? 3 cortex. What do you mean 3 cortex? What do you mean?
Cortex. So kalau kita tengok ke X-ray at the left side tu,
Okay.
So dia left side, right
Left
side
side.
kot. So
which one? This one ke this one?
Left side.
Sebab semua CD kan?
Semua CD. So
This one
left
lah.
side tu nampak macam fracture line dekat dekat lateral tibia tu.
This one.
So dia involve one cortex kot. So I think that dia dah ada.
Apa yang kau masukkan involve ni? Involve apa? Dia betul lah, tapi description tu kurang betul. Sebab orang ceritakan kau kan.
Dia depend.
Samba nak cakap apa? Samba. Tolong kawan kau, Umil.
Kalau nak saya depend based on X-ray, the 2 view, dia ada primary callus formation in at least 3 out of 4. Kiri kanan atau depan belakang tu ada callus formation, tu boleh kita kata dia.
Apa primary callus formation?
Dia macam ada callus formation yang.
Okay, kalau callus formation kau cakap pasal callus formation, ni ada callus formation. Betul tak? Ni unite atau tak? Kan? Hypertrophic non-union also ada callus formation. No, we are looking for. Yes, Afiq dah jawab. You are looking for bridging callus, right? Okay, we are looking for bridging callus. So what bridging callus means is that you have a fracture site, and then if you see at this gambar ni closely, you can see a callus that goes across the fracture line. Okay, and then you can see callus that goes across this fracture line also. You nampak dia putih across ni, dia tak hitam. So in this patient, on the medial cortex ada bridging callus, lateral cortex ada bridging callus, posterior cortex, this is posterior, posterior cortex ada bridging callus, anterior cortex tak ada. Nampak tak? Kalau you see this anterior cortex, tak nampak sangat bridging callus. However, 3 out of 4 cortices, medial, lateral dengan posterior ni ada callus, therefore it's considered union. Okay, what I mean cortices is because you punya bone tu is a tubular structure. If you take X-ray on AP and lateral, then you will see a total of 4 cortices. You ada medial cortices, medial cortex, lateral cortex, posterior cortex, and anterior cortex. Alright, I hope you understand that. So by definition, for you to say union, 3 out of these cortices must have bridging callus. This one, bila kau punya fracture line dah almost gone, this is when we say is gone into consolidation. Omel? This is consolidation, right? This one is united. This one is consolidation. We aim to get union pun dah cukup, boleh discharge patient dah, tak payah follow up dah. Alright? Okay, I hope you understand. Any questions with regards to complications of fracture? These are the common complications of fracture that you will get. Okay, this is an example of an X-ray of a pseudoarthrosis. Okay, pseudoarthrosis. This is a form of hypertrophic non-union, tapi yang dah lama bertahun sampai dia dah form a new joint. Okay, this new joint dia dah ada dia punya own cartilage, dah ada dia punya own synovial fluid dalam ni. Okay, this one management, although it is a form of hypertrophic non-union, kalau ikut principle just put something to stabilize, it is not enough because dia dah form dia punya own cartilage dan sebagainya. So you have to actually remove the pseudo joint itself and then put an internal fix. Okay? Any questions? Tak ada. Kita start berapa tadi? Berapa kita start tadi?
10.45.
Okay. So sejam setengah lah. Any questions? Tak ada?
Doktor nak tanya. Nak tanya. Kalau kata bone graft ataupun bone transport tu ambil dari mana?
Bone graft atau bone transport?
Kalau bone graft tu ambil dari mana?
Bone graft. Ambil dari mana? Agak-agak. Aku tanya kau balik. What do you think?
Maybe daripada badan patient sendiri.
Dia ada banyak bone graft.
Which bone?
Okay, dia ada banyak types of bone graft. Siapa tanya ni? Anissa. There are a lot of types of bone graft. Dia ada autograft, dia ada allograft, dia ada xenograft. Autograft means coming from the own patient. Allograft coming from other human patients. Xenograft coming from other species. Okay. The best overall is always autograft coming from the own patient. Okay. And often the bone graft that we take is from the patient's iliac crest. So we tahu tak iliac crest? Anissa?
Ya, tahu.
Your anterior part of your iliac crest, that is the extra bone yang Tuhan dah bagi yang kau boleh korek. Kita tak adalah, we don't take a piece of the bone. You can actually open up because your iliac crest kan dia macam sekeping tulang macam tu kan. So we can actually cut the upper part and open it up, and then kau boleh korek dia punya bone graft kat dalam tu. You punya sum-sum tulang dalam tu kau boleh korek, and then kau boleh tutup balik. Okay, so we can get quite a lot lah from there. You can fill up 2 cm, 3 cm boleh fill up. Alright, understand? Any other questions? Any other questions? No? Tak ada? Okay. So kita boleh stop dulu? Boleh? Okay, so if you have any questions, you can ask me ataupun WhatsApp ke ataupun ask the people who's posting with me, then we can discuss it. Okay, so we end with tasbih kifarah.